Okay, now we're going to walk through the shift assessment for a postpartum woman. And the important thing to remember on the shift assessment of a postpartum woman is it is not just a reproductive assessment. It is a general systems assessment. It is a more focused assessment. It's not as in-depth as like an admission assessment would be, but we do focus on areas other than just the reproductive system. As we walk in to do our postpartum assessment, of course, we're going to introduce ourselves and what we're going to do. Make sure that that's a good time for mom, that she's not breastfeeding or something else. We also want to ask our mom before we get started about her level of pain. We want to make sure that she's comfortable enough before we start the shift assessment. If she is needing medications, we want to go ahead and medicate her and wait for that to become effective before we come in and do our shift assessment. We also want to ask about the last time she voided, if she feels the urge to void, because a full bladder can alter our assessment of the uterus. So we want to make sure that she goes ahead and voids before we get started. Of course, we're going to do hand hygiene before we get started. And we'll start with vital signs. So we would do blood pressure and, of course, pulse and respirations. This is a good time as well to check her ID bands, check nail beds, color, that kind of thing. It's also really important that we start noticing pumps, IVs, fluids that these moms are getting. Even though y'all will not be doing IVs this semester, it's important that you start noticing those things. So if this mom has an IV, we're going to check the IV site for any signs of infection. We're going to make sure that it's dripping appropriately. We're going to notice what kind of fluid is hanging, whether she has just plain fluid, if she's getting some Pitocin or oxytocin in that fluid, or not oxytocin, Pitocin in that fluid, if she's getting antibiotics or something like that. We also want to notice what kind of pump, the rate on our pump, and we want to notice what kind of pump. She could have a couple of different pumps. She could have just an IV pump. She could have an epidural PCA pump, or she could have an IV PCA pump. So it's important for us to recognize what is being infused into our patient. Okay, let me come around here, and we'll start our assessment of our patient. Again, we don't need to use gloves until we get to where we know we're going to encounter blood. We're going to clean our stethoscope. All right. We've already done our vital signs, and as I'm having a conversation with her during her assessment, I'm assessing her speech. I'm assessing maybe her eyes as she's looking around, mucous membranes, those kinds of things. I'm also assessing, want to assess whether she has a headache, any visual disturbances, anything like that, spots in front of her eyes. Okay. We are going to listen to breath sounds. And you would listen all the way. Okay. And then remember that we have our mnemonic to help us remember kind of the progression of the shift assessment, that bubble he. So our first B is for breasts. So I'm going to let her know that I'm going to assess her breasts. I'm going to ask her permission to touch before I do. And as I'm looking at her breasts, I'm looking for symmetry. And then I'm going to palpate and see if they feel soft, if they're starting to feel firm, if I can feel that there's any warmth or heat to her breast, that if the milk ducts feel like they're filling. Of course, you palpate both breasts to be able to assess both breasts. And I'm also going to observe particularly the nipple area. If this baby is latching incorrectly, if she's breastfeeding, we might notice some bruising, some blistering, some excoriation of the nipples. And of course, I'm also going to ask her if she is breastfeeding, how the breastfeeding is going. If I do notice nipple trauma, I'm going to encourage her next time she puts baby to breast to let me know, or the lactation consultant know, and request some assistance so we can ensure that the baby is being positioned properly at latch on. And then I'll also give her some anticipatory guidance of what she can expect breast changes wise in the first few days, when she can expect her mature milk to come in. And if she does have any nipple trauma, I'm going to talk to her about some comfort measures that we have available for that. All right. And of course, I'm going to cover her back up and maintain her privacy here. And then we move on down to U, which is uterus. And I'm going to palpate her uterus for tone and for height. It's very important to use the correct technique. You want to support the lower uterine segment with one hand, and then you use kind of this palmar area of your other hand to palpate the top of the uterus. You don't want to use your fingers. That causes too much pressure. So you want to definitely support the lower uterine segment so that you don't invert the uterus. You don't push the uterus down into the vagina. And you just palpate. And what I'm feeling for is hopefully a firm uterus. It should feel almost like a golf ball, very firm. If it's soft and spongy, then we call that boggy. If we have a boggy uterus, then I want to massage the uterus gently, and it should get firm again. The uterus should be midline. If we have a full bladder, it's going to push it up and over, but hopefully we have prevented full bladder by asking her ahead of time to void before we get started. And I'm also going to notice the height of the uterus in relation to the umbilicus. About 12 hours after birth, the uterus is about the level of the umbilicus. And then each day after that, it moves down about a centimeter or about a finger breadth. So that's how we measure the fundal height, is in finger breadths or centimeters. So this uterus really is about 2 finger breadths below the umbilicus. So the way that I would chart that would be a U with a slash and then a 2 underneath it to indicate that the umbilicus is highest up on her abdomen and that the uterus is 2 finger breadths or 2 centimeters below the umbilicus. If she had a C-section, I also want to inspect her incision for any signs of infection, any bruising, any discharge, anything like that. If she did have a C-section, of course, you're going to be very careful as you're supporting the lower uterine segment while you're doing your fundal assessment to ensure that you're not putting pressure directly on that incision site. Okay, our next U would be bowel. So we want to ask Mom, have you had a bowel movement since you delivered your baby? Now, it's not unusual for it to take 2 or 3 days for her to have a bowel movement, but we want to know, has she had a bowel movement? Is she passing any gas? Is she experiencing any nausea or vomiting? Is she able to eat a regular diet? Is she having any difficulty eating? Those are the things that we would want to know GI-wise. We're going to listen for bowel sounds. And we're also going to palpate her abdomen. And we would expect that her abdomen would be soft and non-tender, and that it would be non-distended. Now, if she's had a C-section, her bowel sounds might be sluggish. She might, a couple of days after her C-section, her abdomen might be a bit distended from having gas buildup. Okay, and then our next B would be bladder. So again, we're going to talk to her about voiding. Does she feel like she's able to void completely? How frequently is she voiding? What quantity is she voiding? And we would palpate the bladder just to ensure that it's not distended. All right. And then we have our L, which is lochia, which is that vaginal bleeding, that uterine discharge that women have after delivery. And we are going to put gloves on for this part. Oh, she has no underwear on.